Well, good morning. My name is John, and I'm very pleased and honored to be here, to been asked to talk with you about heart disease. Obviously, a situation or condition very near and dear to me. But it's very important to understand, where heart disease comes from and what kind of diseases you can have, and most importantly, how to prevent them. So we'll try and attack that in due course. The question part at the end is the most important part, I believe. And we'll do our best to answer as many questions of a general nature. I can't be giving individual diagnoses and deal with individual problems, but I'll do my best to answer any questions you have about heart disease or otherwise. In preparing for this with Candace and Anna, we talked about various ways to approach it, and I suggest we spend just a few minutes talking about what the healthcare system and the specialties and family practitioners do, how you get to see someone like a cardiologist. I just do hearts, but there's guys who do neurology and guys who do kidneys and so on. And I thought I'd just spend a few minutes to explain where we get our education, how it fits in, and how we communicate with each other as physicians in the healthcare system. And that will help you negotiate your healthcare problems, because it's not possible in our system for an individual patient to just say, well, I want to speak to a heart surgeon. It doesn't work that way. And so I thought I'd talk a bit about that. So UBC has one medical school, 250 students, spread out over 4 different campuses. And to get into that school or any medical school, you need 3 or 4 years of undergraduate education. Could be in arts or science or whatever. A lot of them do some sort of science. And then you have the 4 years of medical school. And after the medical school, you get an MD degree, a doctor of medicine. But you're not qualified to treat patients yet. You need to have some further training, apprenticeship, as it were, before they license you to do that. And traditionally, that was 1 year of working in a hospital, in the delivering babies, doing surgery, working on the wards, and so on. But nowadays, about half the graduates of the medical school go into family practice, and that's where you have your family practitioner. And most of those people have had extra training to deal with all the multiple different kinds of issues that you present to them. And a family practitioner these days has a 2-year residency program, and each of the major teaching hospitals has one of those. And patient or the students go through, or the young doctors go through working on the wards, and they work a lot of time in the family doctor's office. So you may see a family practice resident in your family doctor's office, and that usually suggests that he's a pretty good family doctor, he or she, because they don't just let anybody mentor these people. And after 2 years, they're family practitioners, and they can go out and set up a practice. As you well know, we're very, very short of family practitioners. And part of that is a lot of that is our own fault. Medical practitioners not doing the funding properly and not paying them the right way. So it's not conducive to be a full service family practitioner, but that's another issue. About half of medical graduates do specialty. And if you go through that specialty program, you become a fellow of the College of Physicians and Surgeons of Canada, and they require anywhere from 4 to 6 or 7 years of extra training, depending on what you do. And in the specialty side, at family practice, I think you understand what they do, but in the specialty side, you can be a clinical, like a non-clinical, you don't treat patients, like a radiologist, an x-ray doctor who reads all the x-rays, who does the ultrasounds, the MRIs, all that sort of stuff. Very, very essential stuff to the practice of medicine these days. You can be a pathologist who deals with the laboratory and with doing autopsies and looking at tissues, like if you have decide if this is cancer or not when they look under the microscope, and that's pathology. And then you have the 2 major groups of specialties, the cutting and the non-cutting, kind of a crude term. But the cutting are the surgeons, and the non-cutting specialists are the physicians. So you have, it's a college of physicians and surgeons. Surgeons could be abdominal surgery, brain surgery, bone surgery, obstetrics, gynecology, all these different areas, urology, which is kidneys and so on. And they are spend their time 2 or 3 days a week operating in the operating room, and the rest of the time in the office or on the wards. The medical specialists can be either adult or pediatric. So you have internal medicine as the adult medical specialist, and the pediatrician is the children's medical specialist. And that's your first level. If you want to go further, you can break those down into cardiology or brain, neurology, kidneys, bowels, emergency medicine. There's all kinds of different areas that you can do. So you could be a pediatric emergency specialist, or you could be an adult neurologist, brain specialist. And that's what happens. And as I said, you can't, as a regular patient, say, I've got a headache, I want to go see a neurologist. It doesn't work that way, because you want to be sure that you're screened properly, as it were, and that you get the right specialist. So you would go to a family doctor or a walk-in clinic or the emergency department, say, I've got a headache. That person would be a generalist, like a family practitioner or a emerge doctor, and they would assess your symptoms and say, this sounds like I can handle this. That's nothing to worry about. I'll do this, this, and this. Or he may say, no, this is something more serious. We're going to do this test, and I'll send you to a specialist. And if it's in the emergency department, it might be right there. If it's in the office, it may be as an outpatient. So that's how that system works. If you have something that could be heart related or whatever, they will say, well, I'd like you to go see a cardiologist or an internist. An internist is the generalist, and a cardiologist is the guy who just does the hearts, like me. And since they work you up and they do various more tests, if they think you need to see a heart surgeon or somebody else, they would send you on. So the cardiac surgeons, the guys who do the cutting, I would send them, most of their patients would come from a heart specialist like myself or a general internist. So you have to go through this system. The reason for that is to avoid wasting time, as it were. You want to be sure you got the right specialist and that they're spending their time doing the most efficient way. So that's how the system works, and why you have to go through the family practitioner, because they can, in a heartbeat, more or less, they can figure out what sort of problem you have, whether it's mild, moderate, or severe, whether it needs immediate treatment or delayed treatment, and what kind of specialist you might need, if someone at all. And that's why it's very important to deal with the family practitioner first. And as far as the heart disease, I thought we'd go through and talk a little bit about the heart anatomy. And just give me a moment here, and we'll bring this up. I've got my little sidekick here.
Yes.
To show us some pictures. There we go.
Okay, there you go. You sorted
it. We got it now? Okay. So this is a diagram which we're going to use, and I hope you can all see it. And it is a moving picture, which will show us what we need to do, and we can get rid of all the bones and everything like that. And it shows the heart. So that's the chest. Obviously, the lungs are over here on the right and left side of that. And the heart is hidden in behind the breastbone that you see on the front. So if we remove the breastbone, you can see the heart beating away there. And it's a three-dimensional structure, so it's hard to show in one picture. When you see a picture, I'll see if I can show that better. That's a different image. That's sort of what you see in your textbooks or biology books, where you have the four chambers of the heart. And I thought if we go through a little bit of how the heart works and how the structures are, that will lead us into the various diseases that we deal with. And then that may generate some questions that you may have about issues or concerns you have. So here you have the four chambers. The two on the right side here, it's the left side of your screen, but we call it right-sided in the body. This is the right atrium and the right ventricle. And they take the used up blood or blue blood coming in from the veins. So this is it's low in oxygen, and this blood goes into the right side of the heart, is pumped into this little antechamber here. It primes the pump, as it were. It squeezes the major chamber here of the ventricle, and it pumps this blood out to the lungs. And again, it's hard to show because it's a three-dimensional structure. So the blood comes in as blue, it gets pumped into the lungs, and that's where it picks up the oxygen and becomes red. And the red blood then comes back into the other side of the heart, the left side, and that's you see those four openings there. The blood comes into this left atrium, which collects it and then squirts it into the main pumping chamber, the left ventricle. That's the most important one. And this one here, you see on the side of the thick muscled one, it pumps the blood to every cell in the body. So it pumps the blood out through the aorta, which goes here, which goes to the brains, the arms, the legs, the abdomen. And the red oxygenated blood gets pumped around by this high pressure system. The valves you see here, there's the mitral valve, there's a tricuspid, are kind of complicated looking structures. And like a pump in a regular water pump or any kind of pump you might see out in the engineering world, they have valves which keep the blood going the right direction. So if the blood comes through the valve here, and then when this chamber pumps, it closes the valve and keeps the blood from going backwards. You don't want the blood going sloshing back and forth. So by having that valve in place, it pumps the blood out through the aorta out this direction. And the two sides of the heart, the right and the left side, are both pumping at exactly the same speed. They pump the same amount of blood, but one side pumps it to the lungs and the other side pumps it to the rest of the body. So the heart is strictly a pump. I don't know about love and all these other Sunday stories that we talk about the heart, but from a physician's point of view, it's strictly a pump. And it is a very complex structure. And in order to adapt to all the demands that we put on it, like walking upstairs or running or going to sleep or swimming or whatever you want to do, you need to adapt the amount of blood that's pumped. And that's where the electrical and the muscular system of the heart come into play to adapt and make sure that your body is getting enough blood and oxygen and nutrients to do whatever you want it to do. And it often increases the amount of blood just by speed and pumping more quickly. So that the heart is in a very coordinated fashion. And if you look at the electrical side of the heart here, there we are. You'll see that there are basically some wires in the heart muscle. The main impulse comes from up here, and it goes through the heart muscle. It goes through electrical passages here to this way station, and then goes down through these wires here to the lower two pumping chambers. And so it's all pumps in a coordinated fashion. And if this guy is told or is indicated that he needs to pump faster, he will. And he will pump the blood or send impulses more quickly, and that makes the heart pump more quickly, or slow down when you're sleeping, for example. And so the four chambers are all under control and under a direction of a higher power, as it were, and that's this electrical system. And there can be problems with that. If this pacemaker, this is the main heart pacemaker, we call it, the SA node, and if it malfunctions, then you might need a pacemaker. And that's, we can talk a bit about that as well. So those are some of the abnormalities that are going to occur. In this wire here, all these wires here, they can break. They can get scar tissue or damaged or cut or whatever. And if they don't work properly, then we put in a pacemaker for that. If we go back to the blood flow of the muscle, because this is a muscle, just like the muscles in your leg and arm and everywhere else, the muscles need a lot of oxygen and nutrients, glucose and so on. And so in order to supply itself with oxygen and glucose and all the other nutrients, the heart has its own blood vessel system. So this is the main two right and left ventricles that are the big muscle parts of the heart. And you can see these blood vessels running on the surface. The lung has its blood vessels, the brain has blood vessels, every single tissue in the body has its own blood supply, but the heart needs to give itself muscle and give its muscles energy and oxygen as well. And so it supplies itself with this oxygen. And that's where we get into trouble with heart attacks. And if we carry that a little further here, this is shows you the blood vessels, the arteries, which are the high pressure ones. And if these get diseased or blocked up or damaged or whatever, the blood flow doesn't go to the heart muscle. And when that occurs, that's either angina, which is chest pain. The heart hurts when you try to exert yourself. If there's not enough blood getting through, the heart has a system of letting you know, and it may be some sort of a chest discomfort. You hear about this angina, can go down the arm up into the jaw. And if you go out for a walk and you feel that discomfort coming on when you are walking, for example, that means you're just not enough blood flow going to one part of the heart muscle. And that can be due to buildup of plaque, which we'll talk about. And that plaque buildup, if it blocks off completely, and that can happen quite suddenly, that produces a heart attack or heart damage. And that's what people end up in in hospital with need a balloon or angioplasty or bypass surgery or something like that. And of course, that's very common disease in this part of the world and a big part of my practice. So those arteries here are the ones that can get blocked, and there are veins as well. They're the low pressure. They take the blue blood back to the right side of the heart. If you look at your forearm and you see, especially on a hot day, you'll see those veins sticking out. That's where they take blood for blood tests. That's low pressure, used up blood, as it were, and that's on the surface. But the arteries to your arm, for example, are deeper in the muscle. They're protected because they're the high pressure ones that squirt when you cut them, as you see on the horror movies. The blood squirting out of the neck. That's the high pressure. This is the low pressure, the veins, and they're not that important in heart disease. But if the different segments of the heart are supplied with oxygen by that respective artery. So this left artery coming down here supplies a large area of the heart muscle there. So if that artery is blocked off somewhere along the route of that blood vessel, that muscle it supplies isn't getting its energy. And if it's temporary, that's angina, that's you stop and it goes away. But if it's permanent, if the blockage is 100%, that's a heart attack. And you've got to get treated very quickly for that. Just to finish off the anatomy a little bit here, the valves, we've done the blood flow, we've done the muscles, and the electrical activity. These are the 4 valves, and they can get messed up too. And there's various diseases that we can talk about dealing with the heart valves. These are the valves that keep the blood going the right direction. And there's 4 of them, and they're quite different shapes and functions, but they basically do the same thing. They keep the blood going forward. And if they aren't working properly, the heart has to work much harder, and it can wear out. The heart literally can wear out if the valves aren't functioning. And there are techniques now to replace these valves surgically or through the groin. By cardiologists, they go up with special tools and can replace or repair valves without the need for open heart surgery in some cases. But traditionally, this is a bypass surgery, and the valve replacement surgery is done by the heart surgeons, opening your chest and stopping the heart. And it's
I've got a mute.
Sorry. What's happening?
And these valves and bypass surgery and so on can be done with an open chest and on a heart-lung machine. It's a very complex procedure. But what we're trying to do over the past 10, 20 years is do those procedures without opening the chest. But we're still very dependent on the heart surgeons for the major surgical procedures. And just to remind you of this is just the 2 left chambers. So that's they filled up the left chamber with plastic, just to show you what I'm saying about it. This is the left ventricle contracting, and that's how it pumps the blood out here up into the aorta and to the rest of the body. So the normal blood flow that I showed you on this earlier diagram, the blue blood comes in the right side of the heart. It goes down to this main pumping chamber, goes out through this tube here to the lungs, and the oxygenated or red blood coming from the lungs, it's got full of oxygen now, comes into this side of the heart, gets pumped out through this big aorta here, and goes to the rest of the body. And that's just another picture showing how the same thing with the blue blood going through the pulmonary valve out to the lungs, and the same thing here, just showing the left side, yeah, or the going here. That's the main aorta, and that's the aortic valve. And this valve, these 2 valves often get messed up and need valve surgery. We'll talk a bit about that. I am jumping around a little bit here, but it's kind of, I'm trying to follow on the flow of this diagram. Now, we talked about plaque and blocked arteries and so on. And I'll show you a picture of what plaque looks like, because that's the commonest thing we deal with in heart disease is plaque buildup. And let's see if I can get a diagram of that. I'm going to have to move that. There we are. So this is a picture of a plaque developing, and whether you had a stroke or a heart attack or blocked vessels in the legs, it's all the same disease. So this is an artery that's got filled up with plaque and then suddenly blocked off on this diagram, and I'll show it to you again. The arteries are the thick, high pressure blood vessels. They're the ones, again, you slit your throat or slit your wrist, the blood comes squirting out. That's from the high pressure. The veins are the low pressure. And these arteries are, as you can see here, have three they have various layers, and they got muscle in them. That red stuff you see there is muscle, and it is used to help maintain the pressure and get the blood to the rest of the body under good pressure. It's like getting water to the system in the municipal water system. You have to have enough pressure to get the water to the individual houses, and in order to get it to the cells, you have to have enough pressure in these vessels to get it to the organs and cells that need the oxygen and nutrients. And so this tube has the blood components going through it. Plaque builds up on the side here. It's actually a growth of tissue. It's not just plugged just like a plug drain. It's not the same as that. This is actually an active inflammatory process, and it's very complex as to how this starts. But issues like high blood pressure, like smoking, like being overweight, like being diabetic, like being inactive, all of the things that you've been told that are good to reduce plaque buildup and heart disease are thought to damage the lining of the blood vessel and start this plaque buildup process, so that they, if your arteries are young and healthy and active and delivering all the blood you need, there's no problem. But if you injure the blood vessels by those processes or genetics, we can't forget genetics. Some people just are genetically inclined to have this plaque everywhere. But if you damage or promote the development of this plaque in your neck, that's a stroke. In your heart, that's a heart attack or angina. If it's in your leg, you have trouble walking. And that's called claudication, where you walk down the street, your legs hurt, that's like angina of the legs, and you stop, goes away, you walk a little further, that's called claudication, and that's due to plaque buildup in the legs. And there's surgery and various procedures for that as well, just like in the heart and in the brain. So it's the same condition. This is one of the commonest conditions in Western society. It has something to do with our lifestyle and our weight diet, of course. And it's all the risk factors that we talk about for heart health are based on trying to reduce the development of this plaque. And I'll show it one more time, just not to gross you out, but that's exactly what happens over years. It doesn't happen quickly, but what the plaque gets bigger and bigger. And what this last part shows you is this flap forms, so that the plaque cracks. And if it cracks, it opens up its core, and that generates a clot. So all this red stuff you see here does develop quite quickly. If this thing ruptures, if the surface of this plaque ruptures, it generates a clotting process which occurs in minutes. And that is what produces a stroke or a heart attack or sudden, very, very severe pain of the leg. So if you don't get the oxygen going to the various organs, the brain, the heart, whatever, you're going to, and they do block off, then unless you get that artery opened, you're going to have permanent damage. In the case of a stroke, the area supplied by that blood vessel that's blocked off for blood will die.
John?
And it will no longer
John,
yes.
you're showing the normal artery slide instead of the plaque slide.
Okay, is that showing up there now?
No, it's showing normal.
You see the...
No, it's showing us the normal artery.
Oh, you're not seeing the same plaque. I'm looking at a vision here, a moving picture. Maybe it's not showing up for you guys. Okay,
no,
we'll get rid of that.
Okay.
Okay, all right, that's good to know. So you're not seeing that that artery there. Maybe it's not.
No, now I see. Now I see the fatty artery. That one.
Oh, you do see. Okay, so when I expanded it, maybe it didn't show up. Does that look okay? You see that blood going through there?
Yes, now we can see that. Okay.
Yeah, I expanded it on my picture and on my computer, and it doesn't show. It's just much smaller this way, but that's fine. So that's the plaque buildup that I was describing, where you have, and I'll show it again here. where you have a normal artery to begin with, where whatever organ it's going to, and very slowly it gets damaged and this growth occurs within the wall of that artery, then this breakage or rupture of the plaque occurs here, and it attracts a clot. And that's the stroke or the heart attack issue. And if you have that occurring on this picture here, if you see it on this dark area there, that's where a plaque and a clot have occurred on the heart artery. And if that occurs, that part of the heart muscle below it, the brownish area that's not moving, that is the area of heart damage. And depending on the size of the area that's blocked off of blood, the heart attack is either small, medium, or large. And obviously, the larger the heart damage, the worse it is. So if you have a sudden blockage here that is not relieved very quickly, this heart muscle below it will die. And that in the old days, they would just stick you in a hospital bed, monitor your heart, maybe give you some painkillers, and you'd be in hospital for 6 weeks, and they just wait till you got better or passed away. But nowadays, when you develop this condition, this persistent chest discomfort, that said it can be any kind of a variety of symptoms in the chest, going up into the jaw, down into the arms, or sometimes just shortness of breath. If that is determined to be due to a certain type of heart attack, the ambulance attendants will come to your place, and you won't even go to the emergency department. They'll take you right to St. Paul's or BGH if you're in a big city like here. And the ambulance attendants will do certain tests and communicate with the cardiologist, and they'll open the lab to do this procedure at 2 o'clock in the morning if it happens to be, because they got to open that artery within about an hour or two in order to save the heart muscle. And if they are able to get in there with a tube, and I'll show you how that works, and open that blockage quickly, they restore the blood flow, and the heart muscle is maybe injured but not permanently damaged, and you can go home as early as 2 days later, which is quite remarkable. On occasion, they will do the bypass operation, which is a bigger surgical procedure, but these days we try to do it, if necessary, by a balloon procedure or angioplasty. And that is heart attack. So if it's just a narrowing, it's the angina, it just hurts, then you stop walking and it goes away. That's a warning sign. And they can go in, they can open that artery electively. But if it blocks off, that's like a bolt of lightning and happens very, very quickly. Let me see if I can show a picture of that. And again, this is sometimes, I don't know if you can see that there now. So there's an artery, let's say in the heart, which is got some plaque in it. And I'll see if I can get this to work here. There's a tube. So what the cardiologist does, if it's 2 o'clock in the morning or it's electively, is he goes up through an artery in the groin. You're awake, he slides a tube up into the heart itself, finds where that plaque is. He can literally pass a wire right down through here where that plaque is, and expand it. And this doesn't always work. There's a balloon there. There's a tube and a balloon, and that balloon expands like that. And that pushes the plaque out of the way. It doesn't remove it. They've tried everything. I mean, they can remove it, but it seems to work best this way. And the balloon squishes the plaque out of the way, and obviously that's immediate. And when they reduce the balloon, which I hope I can reduce here, this is kind of a sketchy thing, but the balloon goes down, they remove the tube, and they may put a stent in, and you hear about this all the time. Now there's a mesh, it's like a piece of screen on the screen door, and this metal thing you see is collapsed. And they put that on top of the same balloon. So they've opened the artery, and this generally just takes a few minutes if everything goes smoothly. And then they expand that balloon the same way with the same balloon. And it's not behaving now, but that stent will be expanded. It's just a technical thing here. I've been playing with this for a while. It doesn't seem to work. But the balloon is expanded, the stent stays in place, the little wire mesh and it stays there and stays with you and keeps that artery out of the open. And that's what stenting is all about. And I'm sorry that technology is not working today. So the stenting can be done in the legs, in the heart most commonly, and sometimes up in the neck in a stroke situation. And that is all done through the groin without open heart surgery. So that's stenting, and that's how they treat blockages in here without operation. In an operation, it's a bigger deal, and they have to open you up and put tubes in and so on. It's a different story completely. But that's how heart attacks and angina is treated. And then once that's done, then we concentrate on prevention or preventing it from coming back again. And that's strong medications, such as cholesterol-lowering medications and various blood pressure types of pills and so on that will give you to be as aggressively as possible to reduce the chance of that plaque building up again. And that same thing applies for strokes, heart attacks, and blockages in the legs as well. It's the same condition. We put you on blood thinners like baby aspirin to keep clotting from forming. You saw that picture I showed you where the clot is formed or triggered by the plaque. And blood thinners, the baby aspirin, are quite effective at reducing that from happening. But of course, they're not perfect. But the main part of it is lifestyle changes, because as I mentioned, the smoking, diet, diabetes, blood pressure, and a lot of other inactivity are reversible, manageable risk factors that we can deal with that of course there's no side effects, they're not medications. We concentrate on those every time. And in addition, we'll give some medications as well. Okay, so if you have a blockage over here on the left side, on the right side of the heart, to be a different kind of heart attack, but it's the same basic treatment. The next thing I want to talk a bit about is heart failure. And the heart is a pump, and it's supposed to pump blood to the rest of the body and get the oxygen going where it should go. If your heart is damaged, like that heart attack, this is a picture of the inside of that last heart we saw, where the tip of the heart here has been damaged, the heart muscle is not working. And so the blood's just kind of pooling there, it's not getting pumped out properly. The heart is failing to pump enough blood. And when that occurs, the kidneys don't work, your brain doesn't work, you get short of breath, your legs swell up with fluid, and you just don't feel that good in general. And that's because the heart's not doing its job. So in that case, we try to treat the cause. Is it a leaky valve? Is it a blocked, in this case, it's a blocked artery. It's probably too late to fix it, but there's medication that can be given, complex medication, again, that can be given to help make it easier for the heart to work. So there's heart failure medication. And we do ultrasounds of the heart to take pictures of it. There's a variety of different tests we can do to look at how much damage occurred and whether it's improving. And this is again, a failing heart due to a heart attack. We talked about valves failing, and this is just one example of what can go wrong with a heart valve. You see here, this mitral valve is supposed to seal nice and tight, like here on the other side. That's a nice, good waterproof seal. But if this valve wasn't made properly, you were born with this, the blood's going backwards. See how the blood goes up into here? And that's a leaking mitral valve. And that valve leak makes the heart work much, much harder. And over years and years and years, the heart wears out. So if this is detected, by examination and by ultrasound, on occasion, if it's bad enough, a heart surgeon will go in and repair that. There are some procedures done through the groin, like by the cardiologist, that can clip that and fix it, but they're just learning how to do that. The main typical treatment for this kind of problem would be a surgical procedure. And the aortic valve can get affected as well. You may have heard about this, and Vancouver's kind of famous for this. Let me show a picture here. Now, can you see that picture there of the two hearts beating? This is what happens with the aortic valve. That's this valve up here going to the rest of the body. That's all the oxygenated blood going through this valve. You can see it's all thickened. It doesn't open properly. That's more normal looking. So this valve is not opening properly. And that's like, can be wear and tear, it can be infection, it can be you were born with an improper valve or whatever. If the valve's not working properly, not opening fully, the heart again has to work very, very hard to pump the blood around the body. And when that occurs, the heart can wear out, and also, and you can literally die from all of this because the heart just fails to function. And if this is detected in a good time, then it can be replaced. And again, typically or traditionally, a surgeon would go in and cut that valve out, open heart procedure, stop the heart, cut the valve out, take it out, and put in a pig valve or a tissue valve. These are made by cow or pig parts, and you don't reject them. They're treated so there's no rejection. And they've been doing this for decades and decades. And it's a very effective way of repairing or replacing a faulty valve. And sometimes you have to go on blood thinners. Sometimes you don't, depends on what type of valve. But it's quite a complex surgical procedure. But it is done when it's going to keep you alive, so it's quite worthwhile. If nowadays they're doing them at St. Paul's Hospital and around the world now with a procedure that avoids surgery, which sounds great. And it is actually worked out quite well. And it's interesting because this technique, this collapsible valve that they can put in through the groin, just like an angioplasty, it was designed and developed in Israel. And they brought the technology over to St. Paul's Hospital, and Dr. John Webb started doing it. He did the first one in the world. And he was very, very smart, and he wanted to do it very carefully, very scientifically, and not just do them willy-nilly. So he established a program, and they very carefully did these valve procedures through the groin, avoiding surgery. They started off in sicker older people who would not have survived surgery, for example. And they found that in these patients who couldn't tolerate surgery, they tolerated this procedure quite well, where he puts the valve in through the blood vessels, like the stenting. And they did it on younger and healthier people. And they've done literally thousands and thousands of these procedures in a blocked aortic valve. And on people, some of them would not have otherwise been treated at all because this surgery was too dangerous. Now they're doing it on healthier and healthier patients. And again, I don't know if it's going to show here, but they put a wire, they go up through the groin, just like the angioplasty. And instead of going into the blood vessel, they go across the valve. And then they slide this very similar technology. It's a balloon technology. And they open up the balloon. I don't know if it's going to work, but I don't know if it's my mouse or what it is. But the balloon opens up the valve, and this balloon gets the valve out of the way, so there's more blood going, but it doesn't really solve the problem. And of course, it's not going to work for me today. Anyways, once the balloon opens the valve, they put in an artificial valve, and through the same thing as a stent. It's exactly the same technology as the stenting that I showed you before. And here's the procedure afterwards. So this, you see it, here's a wire mesh. And what they've done is they put in a pig valve inside the old valve. So the old valve is squished out of the way. You don't remove the old valve like the surgeon would have. They just squish it out of the way. And that was kind of sketchy. They thought this could have caused a lot of problems, but it's turned out to be quite successful. And by implanting a new valve inside the old damaged valve, they can get the blood flow going back to normal out that aortic valve. And that's a very stenting procedure, just like on the, I showed you for the balloons for the blocked arteries in the heart. And that's it. And we got just a couple of minutes or a minute on electrical problems of the heart. We talked about valves, we talked about blocked arteries, a bit about heart failure. The electrical problems we talked about are due to abnormalities of the electrical system. This is a picture of atrial fibrillation, where the top part of the heart is beating in a very chaotic fashion, and it doesn't empty properly. It's not as coordinated, and it's a rhythm disturbance, which can be treated by various techniques. And we can perhaps talk about those if someone has a question about it. I just wanted to show you a picture of a pacemaker, and I can find that. Here's a pacemaker. So if the heart muscle is beating too slow and the wiring breaks down, we can put a pacemaker in. And this is a device like this, and I can show it to you a little bit later. I have a real one right in front of me. But this pacemaker is a computer. They put a couple of wires in the veins into the heart muscle, one into the top and one into the bottom, and that takes over for the natural pacing electrical system that you were born with that is not working. And this computer here takes over, stimulating the heart in a coordinated fashion to allow a good function of the heart. And that's a pacemaker. And an ICD, or a defibrillator, I'll just show you a quick picture of that, is a bigger device. It's very similar technique, but it's bigger, stronger, and that gives you a shock. That's put in if you have an electrical tendency to electrical disturbance that can make your heart stop again, and it can give you a shock and shock your heart back to normal. And that's what this diagram is attempting to show, where the heart has become totally chaotic. The pacemaker defibrillator zaps your heart back to normal. So I think that's about it. I'm going to try and get this out of here and stop sharing and take it over, Anna.
Very interesting. It's fascinating, especially for someone like me. You know, I don't have any medical knowledge. We have some questions. Or someone is asking, may I ask, what is the incidence of rejection? This is about the replacement valves.
Yeah, so rejection never occurs because the valve, it is foreign material. But if they're replacing an organ or skin or tissue or something, you want it to be alive. So if they have they're doing pig hearts in humans, that's kind of a new thing. But any living, moving tissue is alive. It's very prone to rejection. But the valves, they take the tissue and they kill it. They cook it almost. So they take the pig valve or tissue. They actually use the sac around the hearts in cows, and they just use it as a tissue and a very reliable. It's like leather. It's like tanning leather, basically. You can put a leather shoe on that doesn't bother you. It's dead leather. And when they put it into your heart, it's not going to be rejected because it's not alive. It's been denatured, as they call it. It still works, and the valve leaflets will work for decades, but there's no remnants of any pig or cow material in it, and that's done on purpose.
So Angela Smith wants to ask you, please talk more about management of arterial fibrillation. I think that's...
Yeah, just at the end, I just touched on the atrial fibrillation. That's quite common. And it's, if the top part of the heart is fibrillating, it just means it's going like this. It's beating at a very rapid, it's going actually about 300 a minute, which is totally crazy fast. And that's just an electrical disturbance, but it's quite common. And when it occurs, it reduces the efficiency of your heart, because it's supposed to, the top two chambers are supposed to beat like this. And if they're beating like this, that priming of the pump or that little extra help to the main pumping chambers is lost. The problem with it is that the heart can sometimes speed up, and that is not good. Sometimes clots can form inside those chambers that aren't emptying properly. And when that forms, you can get a stroke, which is bad. So many people who are in this irregular rhythm called atrial fibrillation, because it has a tendency to form clots, they go on blood thinners, often forever. But the treatment of the atrial fibrillation itself, sometimes we leave it alone. Sometimes we just slow it down if it's going too rapidly. Sometimes we jump start it or zap it back to normal. We may give you medication to try and get it back to normal as well. There's a variety of different approaches, which are all chosen, by the cardiologist, depending on your specific symptoms and situation. And but a pacemaker doesn't work for that at all. So pacemakers do not work for the atrial fibrillation.
Thank you. So a question from Neil: what's the difference between atrial fibrillation and atrial flutter?
Very subtle difference, but flutter is more coordinated. So in fibrillation, there's presumably some scarring or something in the tissues of the two chambers. And instead of beating like this, they're just beating like, we say, a bag of worms, because apparently that's what the surgeon sees when he looks inside. So it just beating in a totally bizarre way. In flutter, there's actually some electrical coordination to it, in that the electrical activity is going around the chamber and it's beating very fast. So instead of beating like a bag of worms, it's beating like this. So that's flutter, and that's fibrillation. The difference is mostly electrical. You wouldn't know the difference. The complications are the same, but the flutter tends to be transient. It tends to either go back to normal or go to fibrillation. Some people are in flutter long-term, but that's quite rare. But it's just an electrical difference. But the effect, the side effects, you feel a little more, you may not feel quite as well when you're in flutter. That is the same as fibrillation. It's just something that we can see it on an electrocardiogram. But the management is very similar.
Thank you. Anne is asking, please comment on alcohol consumption as it relates to the heart health.
In the 80s and 90s, there was a push that some red wine or white wine might be good for you. And of course, we've got to be careful where the research comes from, because if it's from the red wine industry, you know where that's coming from. But there was some objective evidence that people who had consumed 1 or 2 units of wine, red or white or whatever, or even alcohol, may have less chance of developing plaque and heart attack and strokes and so on. And we kind of followed that for many, many years until recent evidence. And the thought was that no sane physician would ever recommend a patient start drinking because of all the side effects of drinking. So if you've got a therapy, like if alcohol is 1 or 2 drinks a day is not harmful and may be beneficial, that's great. But because alcohol is potentially so dangerous, if you become alcoholic, it would be unwise to recommend people, well, take 2 drinks a day for your heart health. So most guys would never, doctors would never do that, because for every heart attack you save, you could make someone into an alcoholic because of that tendency. Recent evidence has actually shown that no level of alcohol is actually safe for heart health and strokes and stuff like that. So and it may be, again, the side effects outweigh the benefits. And there may be a benefit of the alcohol, and it may be quite reasonable to continue to have 1 or 2 units of alcohol. We talk like 1 beer, 1 shot, 1 glass of wine as being a unit. For a male, up to say 14 per week. Female, maybe 9 per week, because they're smaller body size in general. So those would be the upper limits for general medical health as a rule. But we would never prescribe people to start taking alcohol to help their health, because, again, of the downsides of drinking.
Thank you. Anne is asking, how do I know I have a pacemaker or a defibrillator? They didn't tell me. My heart stopped during an operation, and so I got whatever it is bulging in my chest.
Okay, I have the 2 units here, so you might be able to just by size, and I'll hold those up. This one, see, it's backwards. That's a pacemaker. That's a little, okay, that's a little device. You can see it's about half a centimeter thick and about 4 centimeters across. A defibrillator is twice as thick and twice as big. So if you feel on your chest, and again, this is subjective, but the defibrillator is much thicker and bigger. But the best way to tell is to look. They should have given you a card, or there should be a card coming to identification card as to the serial number, model, make of the device, and it will tell you on that what kind of a device it is. Your cardiologist or internist or family doctor will know that as well. But I mean, you could feel it as being how big it is, but without knowing what, having done it before, it's kind of hard to just tell her over the Zoom. But it's a size thing, and more importantly, it likes to know what happened. Most likely, it's just a pacemaker.
Thank you. Another question: what are any issues after someone had an open heart, after them ending up just tightening the valve to the aorta, and now when I listen to the heart, it just doesn't sound strong?
You can't tell that a heart sounds strong or not strong. I remember as a kid, the doctor used to say, "Oh, a good strong heart." When you listen, you can't tell how strong it is. So the heart's either beating or not beating. and everybody's heart sounds different a little bit, but you can't tell much. What you can tell from listening is the regularity of the rhythm, how regular or irregular it is, and also noise from a valve. So if the valve is too narrow, it will make a certain kind of whooshing sound. If it's leaking, it will make a different kind of sound. And again, a physician can listen and tell which one it is by the timing and the sound of it. But I'm not sure what they did. They may have opened a narrowed valve, and I can't tell what procedure was done to them. But unless the details of that will be available from the heart specialist that took care of them. I can't really comment.
Thank you. We have a few more minutes, and then we'll do our little raffle, and that will be our time. So another question: can stopping high blood pressure medication interfere with the pumping of the heart or other side effects?
No, the blood pressure medication, and the problem is that sometimes these blood pressure medications are used for heart failure or other things. We use some medicines for 3 or 4 different things. It's like WD-40, you use it for many different things around the house. If it's specifically for high blood pressure, then stopping it will only allow your blood pressure to go back up, and your heart will still pump perfectly well. The problem with high blood pressure is that over years and years and years, if it's too high, it can cause damage to the body, to various parts of the body, including building up plaque. So you don't want to stop the blood pressure pill long term, because it can lead to those problems. But in the short term, it's not. If it's just for high blood pressure, the only thing that will happen is your blood pressure will go back up, and you can measure that, you can follow that, but it won't affect by itself the heart function unless those medications are also being used for a weak heart, which is of course pretty common too.
Thank you. We'll take one more question. Have you heard of a negative reaction to the onyx mechanical valve for the aorta?
I'm sorry, what was that, a comment on that valve? What was the question? Sorry.
Have you heard of a negative reaction to the onyx mechanical valve for the aorta?
Well, the mechanical valves have been around for 30, 40 years. They've been making them, and there's some of them are still in working that were put in the 1960s and 70s. The onyx is a particular model, and I don't put the valves in, so I can't tell exactly what issues have been occurring. But there may have been a problem. Sometimes they have technical problems, and I can't comment because I don't know the specific of that valve and what size it was when it was made and so on. It's like in any cell phone or TV, you can have issues and you've got to have a recall, or on cars, you have a recall and you bring them back. And it's a little more difficult to recall a valve when it's been put in your heart, of course. But I'm not aware specifically of a problem with that valve, but I just know that in general, valves, mechanical valves put in the aorta or the mitral position have been used and for decades. They often function decades and decades without any problem. If there's specific recall on this one, I can't comment on that.
Unfortunately, this will have to be our last question, even though there's 18 more messages for you, people wanting to ask questions and making comments, but we're running out of time. And before we end, as you remember, we have our little raffle of this board game set. So if you, John, could pick a name, any name of any at random from the participants that are here today, that person will be the winner of the game set.
I understand. Well, I've been looking at some of the names up here, and I'll just pick Margie, Margie Crawford. I see that name up there. Does that help you?
Yes, Margie, can we see you? Margie Crawford, gallery, where is Margie? Margie, fantastic. Congratulations, Margie. You are our winner today. We will be mailing the set to you later this week. And with that, I think we will just have to thank our fantastic presenter, John. It was really, really very interesting. Thank you all for being here. A reminder to everybody that we have our fitness program. If you haven't joined us yet, please do. It's good for your heart. It's good for your lungs. It's free. It's via Zoom. And if you don't have the information about it, send me a message and I will send you the registration page. And this will conclude our presentation for today. Thank you very much, John.